Jackie, I started recording. Whenever you're ready, go right ahead.
Okay. All right, so good morning. Thanks for calling in for case reviews for the month of May. We have 4 great cases, and without any further ado, we'll move forward. So as always, this information is confidential and privileged. It's protected with the HIPAA law or HIPAA Act, and use and distribution or copying of it is prohibited. The first case is of a 4-year-old female where EMS was called for a fall. The chief complaint of this child was that she was altered and that she also was complaining of the back of her head pain. PPE usage by EMS was maximum and appropriate. Primary survey was that this patient was awake, but mostly responsive to verbal stimuli. Her airway was open and she was protecting it. She had a pulse, but she looked poor with ashen and cyanotic skin, and there's no evidence of active bleeding. Vital signs were obtained immediately upon patient contact with a heart rate of 110. Blood pressure was not taken. Respiratory rate was 40, GCS of 11, and SpO2 was 88%. She was a 15-kilo 4-year-old, and there was no pertinent past medical history to report. The story was that she was trying to catch her younger sibling jumping off of a trailer, and that she had put her arms out to catch him or her, I don't know the gender, and the child fell backwards, striking her head on concrete. She did have a positive loss of consciousness, but it was reported to be less than 1 minute. This occurred early afternoon. Vital signs, as I already previously mentioned, they noted that the little girl was incontinent of urine and that she was following some commands. She was squeezing fingers but refused to move her arms and legs, and she knew she was at home. At 5 minutes, a 15-liter non-rebreather was placed for her hypoxia, and at 8 minutes, spinal precautions were initiated. There was mention in the documentation that the child was removed from the outdoor environment and brought into the house, and it is unclear if that was done by EMS, the first responding, or if that was done by family. At 10 minutes, an IV was established, and she was administered during the call 100 mLs. I put in 20 cc's per kilogram for her weight, would have been 300 cc's if they were doing a fluid challenge. And then at 14 minutes, another set of vital signs were obtained, largely unchanged besides the fact that she now has a blood pressure documented. So heart rate of 108, blood pressure 138/96, respiratory rate of 50, GCS of 11, and end-tidal CO2 is 25, suggesting maybe some hyperventilation. It's always good, which I'm doing right now, is to confirm vital signs in pediatric patients to ensure that what you're looking at is actually inaccurate, because I would imagine this blood pressure is pretty high for a little one. So 110 systolic would be the upper limits of normal for a 4-year-old. At 15 minutes, transport was initiated and she was made a full trauma. 19 minutes, actually what I'll say is that this crew documented that they used all of the devices. It didn't sound like they were using the app, but they were using a measurement device before transport to ensure that they had the right color or the right weight for this child, and they got everything ready, anticipating that this patient may have a rapid decline. So they prepped with RSI meds, dosing, and equipment. At 19 minutes, they checked the blood glucose. It was 120. At 23 minutes, they repeated her vital signs. Her heart rate has improved. Her blood pressure is coming down, still a little elevated. Her respiratory rate is outside of normal, which is elevated at 38. Upper limits of normal would be 24. Her SATs are 100% now, and her end-tidal CO2 is 29. They attempted a second IV, was unsuccessful. They noted that her blood pressure on the next subsequent check was now continuing to decline, with it being 90/44. She still has a heart rate normal for her age. Under 70 would be considered bradycardic. And they started to titrate her IV fluids to deal with her lowering blood pressure. The last blood pressure before arrival to the hospital was 76/45, and she remained tachypnic. GCS now improved to 12, and they arrived at the hospital at 44 minutes. So in reviewing this case, I thought that the crews did an excellent job of documenting the mechanism of injury, the assessments, the reassessments, all of the pertinent information. They did a great job of having a very short on-scene time, 15 minutes, which is within our recommendations for full trauma, and that the care they provided this patient was excellent. In my review of this case, I believe that I asked if they gave the 100 mLs just because as they were monitoring the patient's blood pressure, she only developed hypotension towards the end, and that's why she didn't get a full bolus. And then areas for improvement that I alluded to earlier, the patient was carried into the house, and I wasn't sure if that was related to the first on scene providers or if that was family. So we want to make sure that we are maintaining or initiating spinal precautions early on, especially in a case like this, in that with the hypotension, IV fluids were administered, and my belief is that they probably were administered at 100 mLs, as this was towards the end of the transport when the patient developed hypotension. I'm still waiting to hear back from the crews about that. So patient follow-up in the emergency room, she was transported to PCEL Southwest. She was noted to be hypothermic at 94.8. Her heart rate was 87. Her blood pressure was 105/86, and her respiratory rate was 36. So vital signs had improved besides her hypothermia, still tachypnic. Her pupils were 4 millimeters bilaterally. The physician documented that she had crackles bilaterally. She was hypoxic, requiring supplemental oxygen, and she was lethargic. They supported her for about 27 minutes in hopes that she would either mentally improve or her pulmonary exam would improve, but unfortunately it did not. So at 27 minutes, they moved forward with RSI using etomidate and rocuronium. Intubated at the 5.0 ET tube at 15 centimeters, which is appropriate as your devices would indicate as well, in that it was documented she had significant secretions with frothy sputum with the intubation. Chest x-ray was obtained to confirm the location of the ET tube depth, and they noted that there was diffuse hazy opacities bilaterally. They scanned her head. There was no signs of bleeding or fracture, and they arranged for her to be transferred to Randall's. She ultimately was admitted for 11 days. Let me just make sure I have. She was admitted for 11 days with a diagnosis of fall, concussion, cardiac contusion, neurogenic pulmonary edema with acute respiratory distress syndrome. It was noted during her hospitalizations that she had multiple periods of hypotension requiring pressors. She developed a fever, so they broadened her workup to include an infectious workup as well as antibiotics. So kind of a very strange presentation from a fall catching of a younger family member, TBI, and then hypotension, respiratory failure, fevers. She was ultimately discharged home on day 11. She was documented that she had selective mutism, but ultimately didn't seem to have any permanent neurological sequela from this incident. So I thought this would be a great time to talk about neurogenic pulmonary edema, as this was one of her diagnoses. It was first described a century ago by Dr. Cushing, who was a neurosurgeon, and its incidence is probably underestimated, as this is usually reported as a case report. The pathophysiology is any acute central nervous system injury. So that could be anywhere from TBI to subarachnoid bleed to prolonged seizure to penetrating injury to the brain. In that the severity and acuity of the CNS event is the key factors in determining if this patient would likely develop neurogenic pulmonary edema. So anything that's abrupt, rapid, with a severe elevation of intracranial pressure are at greatest risk. The thought is that the impaired cerebral perfusion leads to exaggerated sympathetic nervous system stimulation, so an excessive catecholamine release that results in cardiopulmonary dysfunction. And then there's 4 pathophysiologies that are summated to maybe be the etiology. And if you guys are interested further, you can look at my works cited to read about those 4 additional ones. I won't belabor it here since they're just postulated. And then the clinical characteristics, there's an early and a delayed presentation. The early presentation is the most common one, and it can start anywhere from minutes to hours after the initial CNS injury. And the delayed presentation is anywhere from 12 to 24 hours. Usually this is pretty profound, where the patient has an abrupt shortness of breath, profound pulmonary edema, frothy sputum, cyanosis, in that any kind of sympathetic hyperactivity is common. So you'll likely see hypertension, tachycardia, febrile state, and then for us in the hospital setting, an elevated white blood cell count or leukocytosis. And the treatment for it is supportive. I will say that all of the literature that I found it's a diagnosis of exclusion. Obviously, in this case, this patient was treated for possible infectious etiology. So making sure that you identify any differentials that need to be addressed, but then supportive. So treating the underlying CNS injury to ensure that this catecholamine release reduces or resolves. So if that would be treating increased cranial pressures in the hospital, starting them on osmotic diuresis, managing seizures, decompressive craniotomy, whatever the underlying CNS injury needs to be addressed so that these catecholamine release is resolved. So in follow-up with our protocols locally, so in the upper left-hand corner, it's going to start off over there. So rapid evaluation of patients and scene should be done to determine need for trauma center care and emergent transport. This is a reminder that any patient 15 years and older from a trauma can come to Peace Health. Anybody under the age of 15 that meets trauma criteria should be going to a pediatric trauma center. And then reminders of some of the physiologic and anatomic activation criteria. The vital signs and level of consciousness, anybody with a GCS less than 14 that was presumably 15 or 15 previously, systolic blood pressure is less than 90, respiratory rates less than 10 or greater than 29, and then for infants, less than 20 in an infant under the age of 1. Anatomy of injury, I want to stress this: any penetrating injury to head, neck, torso, or extremities proximal to elbow or knee. There was a recent case brought to Peace Health that was a BB gun to the head, the chest, and to the proximal extremities that was debated if this should have been a full trauma or not. This is a full trauma. This doesn't say small penetrating injuries. It says penetrating injuries to head, neck, torso. And especially with BB guns, it may seem pretty benign, but there can definitely be significant mechanism of injury that can lead to intracranial entrance or intrathoracic entrance. Of note, my personal experience of a BB gun to the chest by another kid that actually entered into the pulmonary vasculature and lodged in the heart. So these are not benign incidences, so they should be taken seriously. In that particular case, EMS had called medical control. They had been given some bad information, and they came in as a trauma consult, which we upgraded to a full trauma once this was identified. And then other anatomy of injuries would include a flail chest, 2 or more long bone injuries above the elbow or ankle, I believe it was, crushed or degloved or mangled extremities, amputation proximal to wrist or ankle, and pelvic fractures, open or depressed skull fractures. Lastly, mechanism of injury or any kind of high energy impact. So falls greater than 20 feet for adults or greater than 10 feet for children or 2 times the height of that child. High risk auto accidents. I will move on to let you guys read that on your own. And then patients that are on anticoagulation that does not include aspirin, burns, time-sensitive extremity injuries, end-stage renal disease requiring dialysis, patients that are 20 weeks or greater and pregnant, paralysis, and then paramedic judgment. So specifically for this patient with a TBI, recognizing that we're going to be identifying GCS as kind of our indicator of how severe this TBI might be, avoiding any hypoxia or avoiding any hypotension if at all possible, and then giving them IV fluids to maintain their blood pressures to ensure that we don't develop hypotension. Up to 2 fluid challenges, and then managing their airway as needed, and dealing with evidence of blown pupil with hyperventilation goal end-tidal CO2 of 40, and or monitoring end-tidal CO2 with a goal of 40, but if there's signs of herniation, end-tidal CO2 should be directed at 35. Any questions or thoughts?
Just one thing, I just want to make sure we're being clear. Would you agree that if there's a kid that needs an emergent airway intervention or something that won't tolerate crossing the river, that kid should go to Peace Health first in a trauma, even under 15?
Yeah, that's a good point. So anytime, so I guess it didn't show up on that screenshot. So there's 3 indications that they should go to Peace Health and not cross the river if they're under the age of 15. And Dr. Mock brought up that as a good point. As a reminder, that's anybody who's in peri or imminent arrest, anybody in respiratory failure, and then lastly, anyone that you can't gain IV access.
Yeah, you can, Jackie, go back a couple of slides. It's actually on the beginning of the thing, right up there. Unless immediate airway control, vascular access, or arrest.
Yeah.
It does show up there.
Yeah. Perfect. Any other thoughts, questions, pointers before moving on to case 2? All right. So case 2 is of a 24-year-old female. Her chief complaint was that she was having contractions. PPE usage was documented as gowns, gloves, surgical mask, and only one of the 2 providers had documented eye protection. This patient was awake. Her airway was open and she was protecting it. Her pulse was present and there was no documentation of active bleeding at the time of initial assessment. Vital signs, heart rate of 68, blood pressure 152/89, respiratory rate of 26, GCS of 15, SATs of 99%, and weight was 94.8. Of note, her blood pressure is a little bit high for somebody who is reportedly pregnant and having contractions. Her past medical history is that she has depression, and what she had told EMS was that she was G3, P2, and that she was 36 weeks pregnant, and that her previous deliveries were via C-section, and that her current due date was June 2nd. So this occurred at 4:58 in the morning. From what was documented in the chart, that she was in, there's some background noise if anyone wouldn't mind muting themselves. So what was documented in the chart was that she was en route to a local fire station. Upon patient presentation, documented by EMS, was that they took a look and they thought that they saw her umbilical cord presenting. They noted that her contractions were every 2 minutes. They initiated transport at 4 minutes and they started an IV. When they reassessed her again, she had what appeared to be a foot presentation. They coached her to push during the contractions. They delivered the baby's lower half of the body, and they were able to deliver up to the baby's head. They noted that the baby was blue and flaccid. At 18 minutes, the baby was delivered. They noted that prior to delivery, they noted that there was no pulse with palpation of the cord. The baby was stimulated, dried, a hat was placed to retain heat, and a 1 minute APGAR was 5. This APGAR was noted to be 5 for just about everything besides the pulse. The extremities were blue, the grimace was minimal, the activity was limp, and the respiratory rate was slow and irregular. They clamped the cord at that point. And then at the 5 minute APGAR, they noted that it improved to 9. They got another set of vital signs. Mom at 23 minutes with a heart rate of 85, a blood pressure 127/89, a respiratory rate of 22, and a normal GCS. They placed the baby on mom's chest for skin to skin, and they noted that she was having vaginal bleeding. They estimated approximately 250 cc loss. They stated that the patient had not delivered her placenta yet and that they had placed some bulky dressings to the vaginal area. And she arrived to L&D at 35 minutes. So pretty impressive transport time and a lot being done in such a short period of time. Probably not what they were hoping to do, but quick action. So the good here is that they took a look at, I didn't mention it in this part here, but they took a look at her, exposed her, noted that there was something that wasn't hair or head coming out, identified what they thought was initially cord presentation that later became foot presentation. They did document that in the narrative that what they thought was a cord was probably just the toes presenting initially. They also rapidly identified that this patient needed to be transported, that she had a precipitous delivery ensuing, and that they supported her throughout all of this abnormal presentation delivery. They got APGARs, full sets of vital signs, IV access, clamp cord, skin to skin. And I write here for rooms for improvement, but I think that that's just more of a reminder of some of the complications in pregnancy, which we'll talk about in the further slides, and then what constitutes postpartum hemorrhage and how to manage it. I was only able to find limited information for this patient's follow-up. Mom was discharged on hospital day 2 without any complications. I could not find the pediatric or the baby's information, so it's a question mark unless somebody on this call knows. I did find that mom returned 6 days postpartum for a headache and hypertension. Her blood pressures were in the 160s over 90s. She was treated with MAG. They did indicate in her history and physical note that she had her previous pregnancy, which was only 1 previous, not 2 previous to this last one, that she was, it was complicated with preeclampsia, and that they also had to, of note, deliver her first baby by C-section because of breech presentation. During her hospitalization, they were able to switch her over to oral meds, nifedipine, and she was discharged on hospital day 2 with the diagnosis of preeclampsia. So, great time to talk about a lot of the things that was present on this case. Definitely a difficult case, not common. There's 3 types of breech deliveries. The image on the right shows you the 3 types. So frank would be flexion at the hips, but extension at the knees. of the infant, and complete would be flexion at the knees and the hips, and then footling would be, a foot would be presenting flexion at the hips. An issue with anything other than the head delivering first is that it doesn't dilate the vaginal canal enough to allow for head delivery. And that management is ideally by C-section, but if delivery is imminent, you want to avoid traction until the infant is delivered at the level of the umbilicus, the baby's umbilicus. That's what I would say for EMS. As for in the hospital situation, we would be potentially placing fingers into the vagina, delivering the posterior hips, twisting the child a little bit by the hips and extension of the leg, with one leg being delivered first, then allowing for delivery of the posterior shoulder, and then holding the baby with our hand to support the chest and the extremities, and then delivering the head with someone externally placing their hand on the suprapubic area and flexing at the baby's head to deliver the head. I would say the nice news is that we wouldn't expect that from EMS, nor should you be placing your hand in anyone's vagina unless there is a cord presentation. So that moves us to prolapse cord. It's when the cord passes through the cervix with or without any presenting part, so the head or the leg or the arm or whatnot. So if this is suspected, we really should be advocating that the mom stop pushing and then lifting any presenting part off of the cord, because it impairs oxygenation and blood flow to the fetus. If the cord is the only thing that's presenting and you have asked mom to stop pushing, although in our protocols, it goes on to having the mom in extreme Trendelenburg, and then also having them kind of bring their legs up. But it's recommended that we consider moist sterile gauze on the cord to keep it from drying out. And if delivery is imminent, manually reducing the cord and rapidly delivering is what the usual hospital presentation treatment would be. And then lastly, postpartum hemorrhage. So postpartum hemorrhage is, according to the American College of Obstetric and Gynecology's 17's guidelines, it indicated that blood loss greater than 1 liter or signs and symptoms of hypovolemia within 24 hours of a birthing process is considered postpartum hemorrhage. But they do note that any blood loss of approximately 500 mLs in vaginal delivery is considered abnormal, and that you should be preparing for resuscitation. The most common cause for postpartum hemorrhage is uterine acne, and that's going to be either from a large baby, precipitous delivery, so the uterus really hasn't had a chance to incommodate and to start to shrink back, or if there's prolonged labor, so again, kind of like a tired uterus. Other causes for postpartum hemorrhage besides related to uterine acne would be lacerations, retained placenta, abnormal adhesions or adherence of placenta such as accreta, and then any DIC, uterine inversion, or defects in coagulation. Treatment would be to deliver the placenta. I have to ask the people on this call, Drs. Whitwer and Dr. Mock, we don't, from what I could see in our protocol, we're just asking them to kind of do a gentle fundal massage and no gentle traction on the umbilical cord. Is that correct?
I would agree with that.
Okay.
Yeah, correct. No, don't pull on the cord, but
just fundal massage.
Fundal massage is basically you just put your hand.
I'll show a picture.
Yeah, up and around. Now, as long as I unmuted myself, I also should mention that that the protocol for, my preference, if you have a prolapse cord, is to put the mother in knee chest position, but that's just almost impossible to transport a patient in that position. So that's why the extreme Trendelenburg would be the next best choice, but remember, don't keep her flat on her back either. She's going to have to be
left lateral recumbent.
Left lateral recumbent.
Yeah. So delivery of the placenta is usually the first order with dealing with postpartum hemorrhage, and then manual massage. What the literature shows is for bimanual massage. So that's what that looks like. We would not recommend that for EMS. We would recommend this for EMS, which would be external placement of the hand with one hand at the top of the fundus, kind of massaging down towards the umbilicus, and the other hand at the lower abdomen, kind of emulating that you're compressing the uterus to try to get it to contract. Another thing that we can do in the hospital setting that we currently don't have protocols for is for TXA. And then what might be considered for the pre-hospital setting or the hospital setting is if there's any evidence of external vaginal tear, just direct pressure with some gauze might help with getting that under control. Additional thoughts would be uterotonic medications like oxytocin, but you can also have mom start breastfeeding because that is also another natural endogenous way for oxytocin to be released. And then extreme cases would be for an intrauterine balloon, blood transfusions, pelvic artery embolization, or hysterectomy. What I did find in my reading is that they said that you can have the mom urinate and empty her bladder because a decompressed bladder might help with compression pressure on the uterus. I guess in that kind of situation, you have limited options in the pre-hospital setting. So you may consider that and probably have them, I would imagine that would probably mean that they would be urinating on your bed. So for our local protocols, the one thing I did not have in the QA discussion is that the patient should have been on oxygen it's in our protocols that oxygen for all abnormal deliveries. I didn't put in there because I wouldn't have necessarily have moved to do that, but that's a good reminder. Transport all third trimester females in left lateral decubitus position unless C-spine prohibits you from doing that, C-spine protection. And if multiple or precipitous delivery is anticipated, you can request additional ambulances. So for normal childbirth, sterile and clean technique, you're guiding and controlling, but not prohibiting delivery. And then you're checking for cord around the neck and gentle removal if it's found. So nuchal cord, apply gentle counter pressure to the baby's head as it delivers to prevent a precipitous explosion out. And then assist delivery of shoulders and rest of body. You're going to be, after delivery, assessing the infant per our neonatal resuscitation protocol, which I did not put in here. And if there's no resuscitation needed, such as it's a term child, they're breathing, they're crying, there's great tone, you would move on to wiping the nose and mouth of any secretions, drying the infant and placing on the chest for skin to skin. Make sure that you don't have any heat loss by covering the baby with a clean, dry blanket, and then assessing APGARs at 1 and 5 minutes. At 30 to 60 seconds after delivery, you want to clamp and cut the umbilical cord 6 inches from the infant. And if resuscitation is needed, the cord may be clamped and cut as soon as necessary. One note is that make sure that you clamp the cord before you do any. If there's some reason that you can't cut it, that you'd at least clamp it before putting the child on the mom. I have had a case where the baby was put up on the chest and the cord wasn't clamped, and there was significant anemia in the child because of basically kind of osmosis. I guess you can think of it as down, is that the baby was at a higher level than the placenta for a prolonged period of time. And then do not delay in transport to deliver the placenta. After the placenta has been delivered, gently externally massage the uterus, the second image that I showed you, to encourage contractions and prevent bleeding. And in our protocol, it also indicates that 500 mLs or greater is considered postpartum hemorrhage, and that you would continue the uterine massage, treat for shock, and let the hospital know that you suspect postpartum hemorrhage. All right, and then of these two concerns for this delivery, both the breech presentation and the initial concern for prolapse cord. So for breech, you're going to allow the mom to push, but do not pull the baby, gently extract it. From what the literature shows is that supporting the baby up until it's delivered at the umbilicus. So there should be no pulling. Support delivery. To support the delivered body and extremities on your hand and arm. And if the head is not delivered, place a gloved hand in the vagina to form a V around the baby's mouth and nose should it begin to breathe. And then prolapse cord, as Dr. Whitwer had mentioned, knee to chest or extreme Trendelenburg, but being cognizant that we should also try to keep the baby off the vena cava the baby off the vena cava by having mom in the left lateral recumbent, and that you're inserting a gloved hand into the vagina and lifting the head and body off the cord. You can observe the cord for pulsations, and then rapid transport. It's a long case. Any other thoughts, concerns, considerations before moving on to the next case? All right.
Just to mention that the case does inform us that a significant number of eclamptic and quote preeclampsia occurs after delivery, usually up to 3 weeks, but sometimes as long as 6 weeks out, and it has the same problems of hypertension, headaches, blurred vision, pedal edema, and then patients can go on to hypertensive crises and also into seizures from eclampsia occurring postpartum. We used to think it was only prepartum and usually term pregnancy, but it happens afterwards too.
No, that's good. And the other thing is that, we teach the treatment is delivery of the child, but if the child is already delivered, then that's really not the treatment, right?
Right.
And I'd add that you could also not only have seizures, but intracranial hemorrhage from that accelerated hypertension, which I think that the woman I had was 2 weeks postpartum, altered mental status, and she had a bleed from her eclampsia. So great reminders, and also a reminder with identifying your patient having hypertension during the delivery period. All right. So the next case is of a 49-year-old female who was at home. Her chief complaint was that she was having slurred speech. PPE usage was maximum. Primary survey was that this patient was awake, her airway was open, and she was protecting, her pulse was present, and there was no signs of active bleeding. Her initial vital signs were obtained shortly upon arrival. She was known to be tachycardic at 107, hypertensive at 154 over 126, respiratory rate at 20, GCS of 14, and average weight at 77 kilos. No previous history was reported, and that apparently her symptoms started abruptly at 8 p.m. She was complaining of dysphagia, ataxia, and when EMS noted her walking, she was dragging her right foot. So EMS arrived 16 minutes after the onset of her symptoms. This was on Mother's Day. She had gotten home, was celebrating with family. She had 2 glasses of wine, and while dancing, and I believe that the timeline that EMS documents is that she got home around like 5:30, 6:30 or something like that. So she was home for a bit, drank 2 glasses of wine, was dancing, and while dancing, she started having word-finding difficulties, slurred speech, and ataxia. At 11 minutes, a blood glucose was obtained, and at 13 minutes, a BFAST and LAMS was performed and documented. At 14 minutes, transport was initiated, and they initiated as a stroke activation. A 4-lead was obtained shortly after transport was initiated, and a second set of vital signs was obtained as well, noting that she was more hypertensive than she had previously been at 160 over 100. They arrived to Legacy Salmon Creek at 23 minutes. So in review of this case, scene time was excellent. Blood glucose was obtained. Last known normal was documented. BFAST and LAMS was obtained and documented. They didn't attribute all this to just drinking too much. They did put her on a 4-lead. They activated her as a stroke alert, and they went to the appropriate destination for the presentation. As Legacy Salmon Creek was not a place that they could not or should not have gone to. The only thing that didn't occur on this call that could have been better was an SpO2, as that's one of our key performance indicators for the state. Dr. Mock, do you happen to know how she did?
She did well. She got thrombolytics. She started on the rehab process in the hospital, but was discharged home doing outpatient rehab. So, and I just want, I mean, the stroke coordinator brought this case to me as just an example of, great clinical acumen by EMS to pick this up even despite the alcohol.
Excellent. Was there any abnormalities picked up by CT imaging or MRI?
CT was normal. The MRI showed a large left parietal stroke.
Excellent. So, yep, that case was referred to me by Dr. Mock because of excellent care. Oh, were you going to say something?
Dr. Gavloff, what I didn't notice the LAM. What was the LAM score?
I'd have to. I don't remember. Actually, no, I do remember. I don't. They wrote under the protocol or under the procedure. They said no large vessel occlusion suspected. So I think that that's based off of a lot of them were zeros, but let me see. But that, yeah, I was going to present the LAM score, but there was not one obtained, so I'm assuming it's a 0. There was not one recorded, so I'm assuming that was a 0.
Okay.
Because I double checked with our indications for Peace Health and whatnot. So this one was a great case of a stroke that was identified early, brought to the right hospital. All the key performance indicators were met, and because there's not a lot of other stuff to discuss about this one, I thought I'd talk to you guys a little bit about TPA, and that it's a drug that is relatively new in our toolbox. So kind of found some information about its history. So it only was first identified in the late 1940s. Initially, some Danish researchers in around 1946 were studying enzymes that they reported on later to be determined to be TPA, or tissue plasminogen activator. In the 50s through the 70s, others were studying clot-dissolving agents, but really hadn't been robustly studying TPA. And in 1976 to 1980, some Belgian researchers were able to isolate TPA from melanoma cells. So back from the Danish researchers, now some Belgian researchers were able to actually find its existence as a direct enzyme, and they were able to prove that it was able to dissolve some clots in animal models. In 1982, labs were able to basically were able to express recombinant TPA, so they were able to produce it in large enough volumes for it to be commercially used. And in 1982 to 1987, TPA was first trialed on cardiac patients or cardiac, or I should say, myocardial infarction patients. It wasn't until 1986 that the FDA approved TPA to be used in MI patients. And after that period of time, the mid to early 90s, they started to present, researchers were starting to present information that TPA could also be used for strokes, showing that it had good outcomes with low risk of hemorrhage in animal models. And that data was extrapolated to some clinical trials on humans, which was where we first identified stroke teams and protocols indicating to use TPA within the first 3 hours. So really not until the early 90s. And then in 1995, the FDA approved TPA not only for MI patients, but also for stroke patients. So really, TPA is an agent that has been identified just recently and included in treatment for strokes recently as well. And that, lastly, I wanted to present in 2014. Researchers were able to prove that clot retrieval was more effective than TPA alone with large clots and large cerebral arteries. So just a short period of great advancement. So guidelines for early stroke treatment. We want, the one proven thing is that no matter what, is transport rapidly to the closest stroke center that can administer TPA. The goal is within 3 hours of last known normal. That this might be stretched a little bit with wake-up strokes because they can get a stat MRI to determine if they would be potentially beneficial in getting TPA. In that, if a patient comes and presents with non-disabling stroke, usually like a NIHSS of 1 or 2, this goes up in the 20s. So 1 and 2 is pretty minimal. They don't get TPA because of the risk benefit for giving TPA, in that we need to get a blood glucose on all of our patients before we're giving TPA and a CT of their head to make sure that they're not experiencing a hemorrhagic stroke before moving forward with TPA administration. From what I was able to find, there's not any evidence that says that there's large benefit to bypass a TPA capable hospital to get a thrombectomy, although the data does show that thrombectomies have better outcomes than TPA alone for large clots. So that's the indication for going to Peace Health for the ability for thrombectomy, and that our interventionalists will want imaging of the blood vessels, or a map of the blood vessels, and that's either done by CT angiogram most commonly because it's much faster, or an MR angiogram, and that depending on the site, it's up to 24 hours that they can do a thrombectomy. All right, and then just our protocol, which I feel like I've looked at it 100 times or you guys have looked at it 100 times too, but we'll look at it again. So doing a BFAST, remembering that's balance, eye, face, arm, speech, time. Any positive findings should indicate that you need to perform a LAM score. So facial droop, arm drift, grip strength. What we are asking you is not only to document in your narrative, but also document your LAM score in your Pulsera report so that the neurointerventionalists will be aware of this patient coming in and their need to potentially intervene. And then make sure you check a glucose. If bleeding suspected, you want to maintain ventilation target of end-tidal CO2 of 35. You want an SpO2 on every one of these patients because you want to maintain their SATs of 94 to 98%. If you don't think there's a bleed, end-tidal goals are 35 to 40. You want to reassure those patients, trying to reduce any anxiety. And then just because the patient can't talk doesn't mean they can't hear. and transport emergently if the patient meets any of the following criteria: any positive BFAST less than 24 hours. That's even if it resolves in front of you. Any patient that has profound paralysis, aphasia, or comatose state, and you want to notify the hospital to appropriately be ready to receive you. And lastly, patients should go to Peace Health if their LAMP score is 4 or 5, if they're over the age of 80, if their symptoms are more than 3 hours but still less than 24 hours, if you suspect a bleed or their profound presentation like as paralysis, aphasia, or comatose, the closest stroke center for all other patients. And as a lot of our EMS crews here on this call have done, if you have a patient that is adamant that they want to go to Legacy Salmon Creek with a possible stroke and they meet the criteria for going to Peace Health, you can call online medical control and we can assist you in that process. Any other thoughts or questions? All right. Last case, 16-year-old male found at the curb vomiting. He reported he overdosed. PPE usage was appropriate. Patient was awake. He was open. His airway was open. He had pulse. There was no active bleeding. Vital signs were obtained by a first responding crew, noted to be tachycardic at 165, hypertensive at 150 by palp, GCS of 15, and normal kilo patient. His past medical history included depression, ADHD, and previous suicide attempts. He reported to EMS that he took quantity 20, 50 milligram sertralines, and quantity 20, 50 milligram trazodones approximately 22 minutes prior to their arrival, and that he was drinking all day. He had told EMS that he hadn't vomited any of the pills up. Blood glucose was obtained, which was normal 99, and at some point, Bayer was dismissed or let go. At 8 minutes, he had another set of vital signs that noted that he was still tachycardic at 138, hypertensive 150 over 89, respirators of 20, GCS of 15, but SATs reported at 84%. He was placed on 4 liters nasal cannula. They documented, actually, that set of vital signs was probably after they ambulated the patient to the ambulance. So they documented that they ambulated the patient to the ambulance with assistance. In the ambulance, he was lethargic and breathing ineffectively. They documented that initially they were holding Zofran because they wanted him to be able to vomit since he overdosed. But because of his worsening mental status and concern for airway protection, they moved forward with administering Zofran. So that probably is the 8-minute time. At 11 minutes, he was placed on a non-rebreather, reassessing him. And I believe at some point before intubation, they called Bayer back. Before intubation, they noted that he was becoming more slurred, more incoherent, and he would only withdraw from pain. He didn't follow any commands anymore. They rechecked his vital signs. Now his heart rate's 110, blood pressure of 121 over 65, respirators of 18, GCS of 9, SpO2 of 97% on supplemental oxygen. So they decided to move forward with RSI because of his rapid decline in his mental status and his inability to protect his airway and already respiratory failure requiring supplemental oxygen. They RSI'd him with 200 of ketamine, 150 of sucks. They used video laryngoscopy and intubated on the first attempt with 7.5 tube. At 28 minutes or 4 minutes after intubation, they treated him for post-intubation sedation with fentanyl, initiated transport at 31 minutes, and treated him with a sedative 200 milligrams of ketamine, repeated vital signs once more before hospital arrival, now just notable for hypertension at 163 over 97, GCS of 3, and end tidal of 38. So in review of this case, serial vital signs, management of hypoxia and airway, history of attainment about what he ingested, when he did, and if he was able to vomit any of it up, and post-intubation sedation was appropriate. Where we could do better is getting a 12 lead early on, if time allows, poison control. Zofran rationale, I think that if you've I personally would just give Zofran as long as I didn't think that this was going to prolong their QTC or further complicate their overdose, which I indicated in the review is get a 12 lead and then give Zofran, especially because he's already hypoxic when you get your first set of vital signs that he's 84% and vomiting. Contact family if you have a minor, if able to, and then make sure that you aren't prematurely releasing your additional assistance if you already have a patient that is sick. In the emergency room, a 12 lead was obtained. Sinus rhythm, notable QRS of 100 milliseconds and QTC of 475. Poison control was contacted. They informed them to watch his QRS, and if it's greater than 110 milliseconds, to start him on a bicarb drip or at least administer bicarb and watch for serotonin syndrome. The doc was able to get a hold of mom. His labs were notable for no alcohol, despite the fact that he reported he was drinking all day, but his urine drug screen was positive for marijuana. He was transferred to Randall's. One, he's a pediatric, and although I'll just leave it at that. He was extubated on hospital day 2, and no point during his hospitalization did he have any signs of serotonin syndrome. He was medically cleared on hospital day 3, and as of writing this this lecture, he still awaiting psychiatric placement at Unity. So serotonin reuptake inhibitor overdoses, both the trazodone and the sertraline he had, put him at risk for SSRI overdose. It's a commonly prescribed antidepressant. Prescription indication could also include obsessive compulsive disorder, panic or eating disorders, and anxiety. The mechanism of action is that it inhibits SSRI reuptake, which also can inhibit sodium, calcium, and potassium ion channels. Serotonin toxicity is a clinical diagnosis. Patients will present with autonomic stimulation, so tachycardia, hypertension, potentially febrile, altered mental status, and neuromuscular excitation. The minor symptoms might be just vomiting and somnolence, sweaty, and dilated pupils, but severe presentation would be decreased level of consciousness, seizures, and EKG changes, such as QRS prolongation. Of note, treating fevers with Tylenol or NSAIDs would not be indicated. There's no rule since this is fevers usually related to muscle rigidity. And then management would be starting an IV, getting them on the cardiac monitor, getting an initial 12 lead to look at their intervals, treating with IV fluids as needed, and stabilizing and supporting their vital signs. If they have seizures or agitation, you can give benzos. Droperidol and Haldol should not be given for any agitation, as this could potentiate their overdose. In that the prognosis when identified and treated is pretty good. From the data I was able to find regarding poison controls reports in 2016, only 100 patients nationally had passed away or succumbed to SSRI overdoses. So poisoning and overdose, universal precautions: treat shock, treat altered mental status, treat airway issues, and contact medical control, poison control. I know that it says 1-800-709-0911. If that's easy for you guys or it's already in your phone, excellent. The number that I use, which is the same number for anywhere you're in the country, is 1-800-222-1222. Anyways, and in specific overdosing, poisoning, in regards to tricyclics or antidepressants, is that if tachycardic greater than 110, dysrhythmia, widening QRS, or seizures, bicarb would be the indication, would be the mainstay of treatment, which we'll be doing bicarb bolus of 1 milliequivalent per kilogram slow IV push. If your patient's QRS is prolonged and they have had multiple potential doses of bicarb, then other causes for this arrhythmia should be considered, such as administering magnesium, 2 grams, and then if they have seizures, you would be treating them with Versed. Here's our chart for toxidrome tables and sodium channel blockade. is kind of the same thing that I just talked about previously, but here it really indicates that sodium bicarb is the mainstay, which it is, unless they're having a seizure. Any questions or concerns? All right, so in summary, the picture on the left up here is for neurogenic pulmonary edema. Any CNS injury that is severe, leading to an increased intracranial pressure, can potentially have pulmonary edema associated with it. And usually the most common presentation is going to be within the first few minutes to hours after the initial insult. For this picture, it's a reminder of pregnancy, that if you have a prolapse cord, you should not have them move on with contractions unless imminent delivery is anticipated, and you're going to be using a gloved hand to lift the presenting part off of the cord. If they're breech, you're going to be assisting. Reminder back to prolapse cord that you can do the knee to chest and reverse Trendelenburg unless you're moving towards delivery. And then for breech presentation, you're assisting the mom with her contractions and not pulling the child out. TPA here on the upper right hand corner is a newer drug in the last 70 years, but really for us in the last 30 years for stroke indication, and that's the whole mainstay of why we identify our patients quickly so that they are a potential candidate for TPA when they get to the hospital. And that sertraline is one of the SSRIs, and that this can lead to serotonin syndrome. We want to get a 12 lead to identify intervals and potentially treat with bicarb if indicated, manage your airway issues and manage any seizures. And that these patients usually have a good outcome as long as we identify and manage the issues that develop along the way. All right. Thank you for your guys' attention. Feel free to email or ask me or call me about any questions or concerns that you guys have about this case or any cases in the future, and have a great Tuesday.
Thank you.
Thanks, Dr. Gadbois.
Thank you.